Good morning, everyone, and welcome to Grand Rounds. It is my pleasure to introduce our speaker, Dr. Amy Kontorovich. She is an associate professor of medicine in cardiology and genomic medicine at the Icahn School of Medicine at Mount Sinai and is also the director of the Center for Inherited Cardiovascular Diseases. She also serves as the medical director of the Adult Cardiovascular Genetics in the Zena and Michael A. Weiner Cardiovascular Institute and is core faculty in the Cardiovascular Research Institute. Dr. Kontorovich received a Bachelor's of Science in Engineering in Bioengineering from the University of Pennsylvania and MD and PhD degrees through the Medical Scientist Training Program of the NIH at Stony Brook University. She completed residency in internal medicine and fellowship in cardiovascular medicine at the Icahn School of Medicine at Mount Sinai, during which she received specialized training in the genetics of cardiovascular diseases. Dr. Kontorovich's clinical practice is focused on the diagnosis and management of individuals with heritable cardiovascular conditions, including vascular connective tissue disorders, aortopathies, cardiomyopathies, channelopathies, and sudden cardiac death. And her laboratory conducts translational and clinical research to further understand the genetic relationships in cardiovascular diseases, including phenotype first or genotype first approaches, the genetics of myocarditis, hereditary transthyretin amyloidosis, among others. Her research has been funded by the New York Academy of Medicine, the Children's Cardiomyopathy Foundation, the NIH, and other industry partners. She is highly regarded as an expert in hereditary cardiovascular disease and has served as an invited speaker and panelist on the topics of genetics and genomics of cardiovascular disease at numerous regional, national, and international meetings. Please join me in welcoming Dr. Kontorovich for Grand Rounds.
Thank you. Good morning. It's great to be here. It's great to be back with the Department of Medicine. Having trained here, I enjoy interacting with residents and faculty in the department, so I'm so glad to be here today. Thank you. So when I posted the title for this talk, Ron Tamler wrote me back right away and said, "Really? You're really undercutting your mission here." So let me just clarify what I would like to talk about today. As you will see in the next hour or so, I'm a champion for the value of genetic evaluations in working up cardiovascular diseases. But what I want to convey is that the genetic test itself is not the end-all be-all. And hopefully you'll walk away from this talk this morning and understand that a comprehensive approach is really important when trying to get to a genetic etiology for cardiovascular diseases. These are my disclosures. And here are the learning objectives. So I'd like to help you recognize the impact of defining genetic etiologies for a range of cardiovascular diseases, describe some of the pitfalls that we've seen in play when genetic testing is performed in a bubble, and also introduce you to Mount Sinai's relatively new Center for Inherited Cardiovascular Diseases. So let's just dive right in with a case of an individual that we saw in our cardiovascular genetic clinic 2 weeks ago. This individual is highlighted by the arrow here. I hope you can see. Here we go. Okay. This is a 33-year-old male. Of note, his wife is currently 22 weeks pregnant with their first child. And he came to us because his sister had suffered a cardiac arrest and was essentially now, very limited cognitive function. In the aftermath of her cardiac arrest, and she had no prior cardiac history, in the aftermath of her cardiac arrest, she underwent genetic testing. And 2 pathogenic variants were identified on her test, one in a gene called KCNQ1, which is associated with long QT syndrome type 1, and the other in a gene called desmocolin-2, which is a desmosomal gene that's associated with arrhythmogenic cardiomyopathies. So this individual was coming to us to be tested for the 2 familial variants, appropriately so. But the tragedy in this case was that his sister's daughter had been diagnosed clinically with long QT syndrome, and no one had thought or recommended to do genetic testing on her. Had they done that, they would have identified, which was later realized once her mother had the testing, that she was actually positive for the KCNQ1 mutation. And she had a molecular diagnosis. This would have prompted her mother to be at least recognized to be a long QT carrier, potentially also have other cardiac testing, potentially picking up risk factors for sudden cardiac death, potentially mitigating the risk of sudden cardiac death with treatment, and potentially avoiding the devastating consequence of a cardiac arrest. So this case really highlights the concept of thinking about not just the patient sitting in front of you, but the whole family, and the implications of working up a diagnosis to the molecular level in the most affected individual. And in cardiology, we're pretty good at picking up risks using conventional markers. And in medicine, we all do this too. So recognizing lipid profile, blood pressure, even family history as part of the medical decision making. But what we really want to emphasize now is how to get the genetics into the mix, and sometimes even before some of these other risk factors, thinking about genomic and genetic risk. Let's just anchor the conversation in an overview of heart disease and genetics. So most of what we're going to talk about today are the type of heart diseases that we call Mendelian or monogenic. And this figure can apply to really a lot of genetic diseases, but I'm just giving you examples in the cardiac sphere today. And what you see is that on the x-axis, the allele frequencies from very rare variants in the population to very common variants in the population. And in the y-axis, you see an expression of a term called penetrance. And penetrance refers to the likelihood that a person will develop a disease if they carry a particular genetic variant. So that's expressed here from low to high penetrance. So if someone has a highly penetrant genetic disorder, they're very likely to have the disease if they have the genetic marker. And everything we'll talk about today pretty much sits within this bubble. High penetrance, rare variants. But just to be aware, there are emerging forms of genetic association, even in complex and common cardiovascular diseases, and things like hypertension and peripheral artery disease, atrial fibrillation. And these are largely characterized by common variants that have low penetrance, where there's multiple variants that confer an effect. And you may be hearing about a concept called polygenic risk scores, and they're usually derived from genome-wide association studies. So that's sitting in this bubble here. Okay, a couple terms. I just presented the concept of penetrance. Most of the cardiovascular diseases that we see in our clinic have reduced or incomplete penetrance. Sometimes it can be age-dependent or sex-dependent or environmentally mediated. And there can be pleiotropy and variable expressivity. So individuals with the same genotype can have very different presentation, range of severity. And that helps us kind of discuss a few misconceptions. So sometimes we hear misconceptions around the idea that if people have a different onset of disease and a different presentation, that means it's a different disease. So that's not always true because of the variable expressivity. Asymptomatic individuals are not at risk. Again, you can have delayed penetrance, you can have incomplete penetrance. Some disorders that have a genetic basis may have syndromic features where you're expecting a particular facial characteristic or a height presentation, when in fact not everyone who has that syndrome will express those characteristics. So you can't assume if you don't see all of the features or many of the features that the person is not at risk. Not at risk after a normal evaluation. So again, because of the delayed penetrance, someone can have a genetic risk marker. They may not show any features even upon complete cardiovascular workup initially, but as they age, they may be at ongoing risk, and so you need to continue surveillance. And no family history, not genetic, again, untrue. You may not elicit a family history because the individual's relatives may have incomplete penetrance, so they don't sort of come out in the family as being notable, but there may still be a familial thread. So this all means that interpreting genomic data in cardiovascular genetics can be complicated. The reality is that there's a great deal of heterogeneity. So mutations in different genes can cause a similar phenotype. And even within the same gene, different mutations, different variants within the same gene can cause either a similar phenotype or a different phenotype. And I hope that you're all familiar with the notion of how genetic testing is performed, but I'll just give you a brief overview. So genetic testing is like a spell check for the gene, and we're looking typically for a single nucleotide, sometimes a few nucleotides in a row that are either changed or missing or added. And the results of genetic testing are graded qualitatively based on whether there's enough evidence to ascribe a pathogenic label to them. So variants that have known association with disease, they've been seen in numerous families with the phenotype, or there are particular characteristics of the variant that are known to be damaging to the function of the gene. Those are positive results. They either get classified as pathogenic or likely pathogenic. But there's a lot of variation in our DNA from person to person. We all have variants among our 20,000 genes that, by and large, do not cause disease. This is a donut plot of a study that was published a few years back from the UK that showed that basically 99% of people have at least one type of variant in their genes. It may be altering to protein, it may not be altering to protein, but the more genetic testing that we do, the more likely we are to uncover variation. And if the testing laboratory has not seen that variant before, or there's any equipoise about the impact that it might have, then it will get classified as a variant of uncertain significance. If a variant is known to be benign, yes, it'll be classified as benign and not appear on your report. But these variants of uncertain significance are the genetic purgatory of genetic testing, and they're often a frustrating result to deal with because it puts the patient in limbo. They don't know whether the result is actually the cause of their disease or not. But at the end of the day, they're not typically clinically actionable. I'll give you an example in some of the cases where you can sometimes move the needle on a variant of uncertain significance with additional data. But what most of the time happens is you just have to watch and wait. And over time, these variants of uncertain significance can be reclassified. The most likely outcome of reclassification is that they get downgraded to either likely benign or benign. But occasionally, as new associations come to light, additional individuals, unrelated individuals with the same phenotype have testing and more myoses are identified or disease genotype-phenotype associations are identified. Sometimes these are upgraded. So you just have to watch and wait with those results, but it's important to counsel patients that a variant of uncertain significance is really not a mutation. We have this mantra in our clinic. We tell patients it's innocent until proven guilty. Okay, but I thought this was kind of funny. One of the fellows last year came up to me after the fellows lecture and said, "Do you know what VUS means in Yiddish?" So apparently it means what? Like, what is this? So keep that in mind, VUS, what? Okay, so genetic diagnoses inform disease management, risk prediction, and family screening. I'm going to take you through some examples to highlight these, the role of the genetic evaluation. But it's just a test, like all other tests that we have in our armamentarium. It's a powerful tool, but you have to take into account the technical limitations of the test as well as the interpretive limitations of the test. There are true positives, false positives, true negatives, and false negatives. So I'm showing you here an example of two different categories of genes that we commonly encounter in our clinic. LDLR gene mutations associated with familial hypercholesterolemia, and a rarer disease, vascular EDS associated with disease-causing variants in COL3A1. So the interpretive specificity of the genetic test for these genes is very good, 99.9%, but it's not 100%. But when you take into account the prevalence of mutations in these genes for LDR, something that's rather common, for COL3A1, something that's much more rare, the positive predictive values can be very different. So you have to keep this in mind when you're doing genetic testing and make sure that you have a high index of suspicion for the disease in question before you send the genetic test. So these are the essential steps to genetic testing interpretation. Number one is choosing the appropriate test for the clinical context. And two is interpreting the results in accordance with gene disease associations. So I'm going to take you through some cases to highlight this. So the first case is a 66-year-old gentleman who had a history of an abnormal EKG when he was 41. He was ultimately worked up and found to have sick sinus syndrome and underwent pacemaker implantation. A few years later, he developed a fib, which was noted on a routine physical, and then he started to be monitored through cardiology, and eventually his ejection fraction was noted to be 35% by age 46. He underwent primary prevention ICD implantation and later had multiple episodes of unstable ventricular arrhythmia requiring ablations, then a device upgrade to CRTD, and notably he was intolerant to therapeutic doses of neurohormonal blockade. His family history when we saw him, his disease started to become apparent at age 41, but we didn't see him until he was 66. He endorsed a family history of his father dying suddenly at age 66, but also needing a pacemaker in his 50s. And interestingly, he also had two children, a 42-year-old son and a 39-year-old daughter with very notable cardiac histories. His daughter required a pacemaker at age 36, and his son a pacemaker at age 41, and his son had also had ventricular arrhythmias. So this was a presentation that was actually very suspicious for a specific genetic diagnosis, and that was confirmed on his genetic testing with the finding of a heterozygous pathogenic variant in the gene LMNA. So LMNA is a gene that encodes the protein laminase C. It's a nuclear envelope protein. This gene is responsible for about 6 to 8% of familial dilated cardiomyopathy, but it's a really important one to think about because it presents differently and it's managed differently, and it's really the only example that we know of in the cardiac genetic space that has 100% penetrance. So the typical presentation is for patients to develop AV or sinus node conduction disease first before the cardiomyopathy. That's really the opposite of other forms of genetic and non-genetic dilated cardiomyopathy. Later developing atrial arrhythmias and the consequences of that, including thromboembolic disease, is a risk if it's unrecognized, then heart failure, then ventricular arrhythmia, and then death. So you have to think about LMNA in young people with new AV block or atypical atrial arrhythmias, even if the EF is normal, because you need to risk stratify for both ventricular arrhythmia and risk for heart transplantation. Now, in recent years, new tools have come to be available to help with risk prediction based on certain risk modifiers that are known to influence the risk of life-threatening ventricular arrhythmia, and those are listed here: male sex, evidence of non-sustained VT on monitoring, AV block, EF less than 45%, and a non-missense type LMNA variant. The ones that we usually see are splicing variants. And you can see here the strata of scores based on a novel LMNA risk score that was developed last year and published last year. And the higher the score, the higher risk of ventricular arrhythmia. Another important thing to take note of is that these patients don't do well with ablations. They have a higher rate of arrhythmia occurrence and progression to end-stage heart failure, as well as mortality. So you can see LMNA is a hallmark example of where a genotype influences outcome in patients who have dilated cardiomyopathy. And there are other examples as well for all-cause events and heart failure and ventricular arrhythmia, but also stratifying arrhythmogenic risk by specific genotypes. And you can see LMNA is here as having a high risk, as having a high risk of sudden cardiac death, VT and VF. And a similar trend is seen with genes in the desmosomal category, genes that encode proteins that make up the cardiac desmosome that controls cell-cell connections. And the genotype also has been shown to influence the likelihood of end-stage heart failure. And you're seeing here LMNA has the highest risk, but DSP is one of those desmosomal genes. It's also associated with a higher risk than other forms of DCM, including genotype negative forms. So as you can imagine, these genetically different and heterogeneous forms of dilated cardiomyopathy can actually appear similar on imaging. The features on cardiac MRI, including distribution of late gadolinium enhancement, can be identical, but the risks are different. So the only way to differentiate these entities is through the genetic workup. You can't really tell the difference in any other way except through genetic sequencing. What about exercise? So this is an important consideration as well. Pinpointing the specific genotype that's responsible for someone's DCM can inform the conversations that you're having with your patients. So in LMNA, there's a class 3 recommendation against high intensity and competitive sports because of the increased risk of sudden cardiac death and progression of cardiomyopathy with this genotype. And same is true with the arrhythmogenic cardiomyopathies and this gene set here that I have listed at the top. What about ICD decision-making? So because LMNA is such a standout example, I'm stressing that, but there's a few other genes that have been flagged as being particularly high risk when it comes to arrhythmias to warrant including them as modifying risk factors in the 2022 ESC guidelines. So ICD implantation for primary prevention is recommended with a 2A classification in patients who even have an EF of just less than 50 if they have one or two or more risk factors, and among them are mutations in these genes here, including LMNA. The other important thing about LMNA is there are impacts of this gene beyond the cardiovascular system. So about a third of patients who have mutations in LMNA will have an elevated CK level. And as you may know, this gene is also associated with neuromuscular disorders, including Emery-Dreifuss muscular dystrophy, limb-girdle muscular dystrophy, and the others listed here. Those who have neuromuscular disease involvement are more likely to have earlier cardiac involvement, yet the cardiac severity does not correlate with the severity of neuromuscular symptoms. So going back to this case, once we had the genotype for our patient, we circled back to him, we asked him about neuromuscular symptoms, and he actually endorsed several symptoms, and we checked a CK level, which was mildly elevated. So we were able to refer him to a neuromuscular specialist on this basis after having elicited both the genotype and this additional information that we wouldn't have really thought to ask about had we not been anchoring our discussion around LMNA. A few other cardiac genes also have expression beyond the heart that can cause neuromuscular manifestations, and that includes Titin, FLNC, DMD, of course, and others. The other notable and final thing I'll say about LMNA, which highlights a trend in pharmacotherapy, is that LMNA was at least briefly part of a clinical trial, the focus of a clinical trial called the ARRAY trial that was testing a novel oral inhibitor of P38 mitogen activated protein kinase as a target specifically for LMNA dilated cardiomyopathy. Unfortunately, the program was discontinued, but this approach of personalized therapies based on specific cardiomyopathy genotypes, or at least genes, is emerging, and we will likely see more efforts to pursue this type of personalized medicine through clinical trial programs. So straightforward genetic results, such as a likely pathogenic or pathogenic variant, are reported in about 10 to 40% of cases. So I'm showing you the positive case just to emphasize the value of a positive result. But keep in mind that the majority of patients with DCM, non-ischemic dilated cardiomyopathy, who undergo genetic testing will have a negative result or an uncertain result. And that doesn't mean that their condition is not genetic. It just means that your test isn't able to capture the specific genetic cause. Okay, here's another example. So this was a 50-year-old man with arrhythmia and cardiomyopathy. His condition started at age 31, again, incidentally noted cardiac rhythm disease that was discovered on an EKG after he had a motor vehicle accident. But later he was diagnosed with AFib, so kind of a similar progression in the last case. His AV block started later. And then his ejection fraction was noted to be down by age 47 with progression to ventricular arrhythmia by age 50. So on genetic testing, he had two variants identified, a heterozygous variant of uncertain significance in a gene called AGL, and a hemizygous variant of uncertain significance on an X-linked gene called EMD. And so this was an uncertain result. And this is a very common situation in our clinic where we encounter one or more uncertain variants. And inconclusive genetic results like this are reported in about 40% of dilated cardiomyopathy testing scenarios. And the variants of uncertain significance I mentioned earlier are frustrating for a lot of reasons, but they also can generate some harms potentially for patients. And this is an interesting study that was published a few years ago that showed a range of responses to patients who received variant of uncertain significance results. And some of the examples of the responses are listed here. So overinterpretation, patients can sometimes think that their variant is pathogenic. Even with all the best counseling in the world, it makes them feel a false sense of empowerment and validation because it isn't necessarily the cause of their condition. For those who realize that it is not actionable, they can feel frustrated, disappointed. They can feel sometimes, an interest in awaiting reclassification, which would be an appropriate response. And of course, there are some positive effects of having genetic testing, like patients feel a sense of health awareness, but these risks still run true. The other risk, and unfortunately this is something that we have seen, is that physicians can sometimes overinterpret VUSs if they don't really understand the type of classification for genetic variants, and even recommend inappropriate actions. So in this case example, a patient who had genetic testing for cancer and had a variant of uncertain significance in BRCA1, even had a provider recommended oophorectomy. So this is a rare but very negative side effect of having variants of uncertain significance, and really important for all of us, even non-genetic specialists, to recognize that a variant of uncertain significance is not a mutation. However, in this case, we were suspicious about the variant in EMD because it had in silico prediction to affect the consensus splice site of the gene, and it was a rare variant that was not previously reported either in patients with Emery-Dreifuss, which is the condition that's associated with this gene, or in healthy population databases. And aberrant RNA splicing is a known mechanism of Emery-Dreifuss muscular dystrophy. So we decided to go back to the patient, ask some additional questions, and check a CK level, which was elevated. And the patient endorsed a history of bilateral elbow contractures since childhood, which is part of the phenotype of Emery-Dreifuss. So we decided to partner with the laboratory who performed the test, Ambry Genetics, to do functional studies to assess the impact of this gene. So Ambry is one of many labs that we use in our clinic, but they happen to offer functional RNA testing for genes typically in the cancer space to adjudicate variants of uncertain significance. They can do these functional studies for genes that have expression in blood cells. So a lot of cardiac genes suffer the unfortunate downside of not being expressed in circulating blood cells, but the EMD gene is. So we were able to obtain help from the lab to do this analysis. And basically what you're seeing here is the splice prediction tool called Splice AI, which predicts that there's a splice site gain here. And then the actual PCR-seq analysis on the right, which is showing that for healthy controls, most of the time the normal spliced reads are incorporated, but the patients who have the EMD mutation make almost no normal spliced reads, less than 1% of the spliced reads. So basically this was sufficient to demonstrate that the variant impacted splicing, and the lab was able to reclassify this as a likely pathogenic variant. So this is one way in which variants of uncertain significance can be reconsidered and reclassified, is with functional evidence for pathogenicity. But it's not always available, and it can take time to generate this, and it's actually very time-consuming, and it's not practical to do this for every variant of uncertain significance. So it's really only recommended if the result has certain features that are very suspicious for a disease-causing effect. So just a little bit about Emery-Dreifuss muscular dystrophy. It's associated with conduction disease and arrhythmias, dilated cardiomyopathy, usually after the second decade of life, and again, the joint contractures and slowly progressive muscle weakness. So this patient was evaluated by Dr. Susan Shin. After we had made the genetic diagnosis, we referred to Dr. Shin, and she identified, again, the elbow contractures, as well as weakness and atrophy and abnormal EMG and nerve conduction studies and an ultrasound with increased echogenicity. So that was sufficient to make the diagnosis. So in this case, defining the etiology of the dilated cardiomyopathy as EMD-related enabled us to make the referral to an appropriate neuromuscular specialist and facilitate extracardiac management and treatment. So I'm going to move on to another case and another phenotype. So we've been talking about non-hypertrophied cardiomyopathy or dilated cardiomyopathy, and I want to turn to hypertrophic cardiomyopathy. So there are many different causes of hypertrophic cardiomyopathy. This is a case example. This gentleman, 75 years old with AFib and hypertrophic cardiomyopathy. You can see that here on the cardiac MRI. You can see at the apex even has an LV thrombus. This is his family. Sorry, I don't know if that's projecting well. This is the thrombus. And this is his family history. Nothing notable on the family history. And he had had this diagnosis of hypertrophic cardiomyopathy for about a decade by the time that we saw him. So when you see patients with a thick-walled heart, it's important to think about the possible etiologies. There's obviously non-genetic etiologies that can cause left ventricular hypertrophy. So not all left ventricular hypertrophy is HCM. But even among patients with HCM, there's a great deal of heterogeneity in the genetic causes. There's the genetic causes we can identify with mutations in cardiomyocyte genes, typically genes that encode proteins within the cardiac sarcomere. And then there are forms of hypertrophic cardiomyopathy that we call phenocopies, where the walls of the heart are thick. You can see that on imaging. But the thickening is coming from some extrinsic material. It's not from hypertrophy of the cardiac myocyte itself. It's from infiltration of another substance. So those are called phenocopies. And then you have HCM that is genotype elusive, where genetic testing can't pick it up. But this is one of the more common cardiovascular genetic disorders. The prevalence is cited at anywhere from 1 in 250 to 1 in 500. So for sarcomeric HCM, with contemporary care, patients can actually have a normal life expectancy. HCM mortality now is actually at the level or even lower than the US general population, with appropriate ICD intervention and transplant, with guideline-directed medical therapy and defibrillators. So we do pretty well with HCM. But this is work from Carolyn Ho's group that showed that across several endpoints, patients who have sarcomeric positive HCM actually fare worse. So you can use the genetic information to prognosticate somewhat in patients with hypertrophic cardiomyopathy. And then there's an emerging field many of you may be aware of cardiac myosin inhibitor therapies. The example that's currently available is mavacamten. And these therapies work at the underlying pathobiology of the disease. So the normal sarcomere has a number of myosin and actin connections here. The myosin head is bound to actin. But in hypertrophic cardiomyopathy, due to sarcomeric mutations, you can see an excessive number of these connections. And the cardiac myosin inhibitors work to minimize those connections. So this phenotype here is what causes both the thickening and the hypercontractility. You see a lot of patients with HCM have ejection fractions above the normal range. And so the cardiac myosin inhibitors reverse that phenomenon and can actually bring your ejection fraction down. It's one of the concerns with the therapies, because in the trials, some patients actually had EFs that went below normal. So this needs to be monitored very, very carefully. And what was interesting in the earliest studies in Explorer is that patients who had sarcomeric HCM with pathogenic or likely pathogenic variants had better outcomes with mavacamten than those who had negative genetic testing. So these therapies seem to do better for patients with this category of genotype, but you would not want to use these therapies in patients who have infiltrative or non-sarcomeric disease, because the disease doesn't operate based on this mechanism. What are some examples of phenocopies? So here's a really important one that I'm sure you're all aware of. TTR amyloidosis is an infiltrative cardiomyopathy that's caused by pathogenic variants, either pathogenic variants in the TTR gene or through a process called senile or wild type TTR, and that's a non-genetic form. But I'm focusing on the genetic form here because that's the basis of the talk today. There are about 130 known pathogenic variants in the TTR gene. It's a very well characterized gene, but the most important one for you to be aware of is this Val142 ILE variant, which is the most common variant in the United States and by some measures worldwide. It's a polymorphic variant in individuals of African American and Hispanic ancestry, and the cited prevalence is 4% of African Americans. So about 2% of the about 2 million Americans between our African American population and Hispanic population. About 2 million Americans carry this particular variant. It's associated with an increased risk for cardiomyopathy and heart failure, and the penetrance is cited anywhere from 60 to 80%. And the important thing about recognizing this as a form of hypertrophic cardiomyopathy in your patients is that, first of all, different genotypes of TTR have different outcomes. But now we have a whole panoply of therapies that are at our disposal. So there are drugs that target the mRNA, the TTR mRNA. These are called TTR silencer therapies. There's an antisense oligonucleotide or a small interfering RNA therapy that can work at the, I say it's like turning down the faucet, basically reducing the amount of transthyretin that's made by the liver and thereby reducing aggregation of amyloid in tissues. So that's one mechanism, and these therapies are approved for only hereditary transthyretin polyneuropathy. Patients who have cardiomyopathy as part of that presentation can benefit from these drugs, but they don't yet have a label approval specifically for cardiomyopathy. So if you have someone with a known TTR mutation, the only way to get them on these drugs is if they have evidence of polyneuropathy. Patients who have cardiac amyloidosis, either wild type, non-genetic, or the genetic forms, will benefit from being on a TTR tetramer stabilizer. So the way that the hATTR works is that the abnormal transthyretin protein destabilizes into monomers and then reaggregates to form amyloids. But these stabilizer drugs prevent that reaggregation by stabilizing the monomeric subunits. And so there's a drug that's currently approved for this label, that's tafamidis, or Vyndamax. There's another drug that's currently in the last stages of development and had positive outcomes in a stage 3 trial, and that's acoramidis, or AG10. Interestingly, the biology of this drug is based on another variant in TTR, the T139M variant, which actually has stabilizing properties. So a really nice full circle where the stabilizing properties of the gene and the human biology were used to inform the drug development. So if patients have HCM due to cardiac amyloidosis, you don't want to miss this, right? This is something that can be disease modifying, that can raise awareness so that you can start them on disease modifying therapy. Okay, so overall, straightforward genetic results, such as a likely pathogenic or pathogenic variant, are found in about 50% of patients with hypertrophic cardiomyopathy, and that can change their management. But again, it's only 50%. So if you perform genetic testing on your patients and they have a negative result, it does not mean that their condition is not genetic. Recognizing genetic etiologies can, again, like the example of TTR and LMNA, it can affect the way you manage your patients. It can potentially affect their clinical trial participation eligibility, inform on restrictions on physical activity, and again, alert you to additional non-cardiac risks. And this table has a few examples, notable examples of genotype-specific considerations in the management of cardiomyopathy, and you can see TTR is on there, but there are others such as GLA associated with Fabry disease. That's another phenocopy of HCM, and a few other examples that I briefly touched upon here, and you can take a look at this paper if you'd like to see more details. So I'm going to switch gears a little bit now and talk about another phenotype that comes up often in our cardiovascular genetic clinic, and that's thoracic aortopathy. So this is a case of a 34-year-old male with aortic root aneurysm, and he had actually been told that he had Marfan syndrome from a young age. He did have several features that could fit with the diagnosis. He had myopia, scoliosis, flat feet. Basically, he had had a murmur detected by his pediatrician, and they sent him to cardiology. And when he was 13, and they said, your aorta is a little bit dilated, we want to watch you. But as he got older into his 20s and early 30s, his aortic root progressed quite significantly. So that by the time we saw him, he had an aortic aneurysm of 5.6 centimeters. So a couple of different terminologies just to familiarize yourself with. So when we say the aorta is dilated, it means that the diameter of the cross-section of the largest segment of the aorta is above the upper limit of normal for that particular individual. And the upper limit of normal is determined based on age, sex, and some physical body characteristic. The best predictor of risk in aortopathy is height. So usually we would use height as our predictor, and there are standard nomograms to help you determine whether an aortic diameter is normal for your patient, depending on the imaging modality. There are specific nomograms for echo, cardiac MRI, cardiac CT. When we use the term aneurysm, it means that the aortic dimension has exceeded 1.5 times the upper limit of normal for that person. And this can become a little bit tricky because the upper limit of normal for a 5-foot woman is going to be different than for a 6-foot man. So in this case, this was a true aneurysm for this gentleman, even though he was rather tall, 6'3", as you can see here on his pedigree. Okay. So on the clinical assessment, we observed a few features that raised a suspicion for a potential underlying syndrome. He had mild pectus carinatum. He had a positive wrist sign, at least on one side, borderline on the left. He had some small joint hypermobility and a few other dermatologic features that were suggestive of a connective tissue disorder, as well as generalized joint hypermobility with a positive Beighton score and a prolonged arm span to height ratio. So we performed genetic testing on a heritable thoracic aortic aneurysm and dissection panel. There's about 35 genes on this panel. And interestingly, he was found to have a heterozygous variant, pathogenic variant, in a gene called SMAD4. And this gene you might have heard about outside of the cardiac world because it's actually associated not only with thoracic aortic aneurysm, it's more commonly associated with hereditary hemorrhagic telangiectasia or Osler-Weber-Rendu syndrome, as well as juvenile polyposis syndrome. And so this gene is associated with an increased risk of colorectal and stomach cancer. When we went back to the patient, we asked him about childhood history of epistaxis, which he endorsed. So that's a feature of hereditary hemorrhagic telangiectasia. That's a major criteria for the diagnosis is epistaxis. And we performed an echo bubble study, which showed a right to left shunt. So we had seen him right before his aortic root replacement. We were able to put in place several recommendations to try to reduce his risk of embolic event due to arteriovenous malformation. And then after he had his aortic root replaced, we had referred him to Amy Lucas for the GI workup, which revealed multiple polyps. So he's undergoing cancer screening at the age of 34, whereas he would be falling short of the USPSTF recommendations just based on his age. So recognition of his genotype was really important in this case. And straightforward genetic results like this, they don't happen often, but when they do, they can be very impactful. So the cited rate for yield of genetic testing in aortopathies is about 10 to 30%. In our experience, it's more like 10%. So why do we do it when 90% of the time it's going to be unhelpful? Again, for these rare cases where it can change the management. And much like in the cardiomyopathy scenarios that I laid out, with aortopathy, again, the imaging characteristics can be identical, and there can be very different risks associated with the same degree of aortic dilatation. So here are some examples of genes that are associated with genetic forms of aortopathy that don't really carry an excess risk of complication. So patients who have genetic testing for aortopathy and either have negative results or have a genetic variant in one of these genes are really at the typical risk for complications, and we usually recommend an aortic replacement surgery or repair surgery when the size of the aneurysm reaches 5.5 centimeters or greater. However, all of these genes in red are associated with a heightened risk of aortic events at much lower aortic diameters. So I gave you we talked just briefly about FBN1 Marfan syndrome. This patient had a SMAD4 gene mutation that's not really on this list. But these genes, the TGF genes and SMAD3, are associated with a condition called Loeys-Dietz syndrome. And even within that syndrome, there are variable risks. So a patient with Loeys-Dietz syndrome might be recommended to have an aortic repair at a diameter of 4 or 4.5. Another standout example is this gene ACTA2. This is a non-syndromic gene, but has a heightened risk of complications, especially in women around pregnancy. And actually, the most recent guidelines, the AHA guidelines, recommend surgery for patients with ACTA2 when the aorta gets to 4.5 centimeters. So patients may not have any of those Marfan-like features. They may have normal stature, no pectus deformity, no scoliosis, no eye problems, but they can be walking around with a mutation in this gene, and it's like a ticking time bomb. So even though, again, the yield is low, the overall yield is low, the actionability of these results is really important. And so there's a spectrum of risk for aortopathy, and it can influence medical management, treatment decision-making for surgery, setting that threshold for aortic diameter for when to operate. I gave you the example of SMAD4, where there's off-target, non-cardiac effect of this gene, so screening for colorectal cancer. And so this is just, to emphasize the importance of recognizing the etiology when you have a patient with thoracic aortic enlargement. In the interest of time, I think I'm going to just skip this case. I was going to present a case with negative genetic testing results on panel sequencing. Negative panel sequencing results are pretty common, even when we have a high suspicion for hereditary cause, either because the patient has particular syndromic features or they have a positive family history. And this was a case example where we actually went a step further and we performed whole exome sequencing because there were so many features that made us suspicious for something genetic. And in fact, we were able to identify a likely pathogenic variant in a gene called FGF16, a very rare disease where fewer than 10 families have been described in the literature and has an association with a skeletal deformity that we recapitulated on hand x-ray. And in this case, this patient that had this result had been going on a long medical odyssey for about a decade without answers, and having this result was very validating for him, and he expressed a psychological benefit. So I've given you a couple examples of when the genetic testing can be informative, but it's really critical to choose the appropriate clinical context for each test, and again, interpret the results in accordance with the known gene disease associations. So how do we recommend doing this? The first step is always to identify the proband in the family. The person who should have the genetic testing is the one who has the most significant or overt manifestations of the disease. And it may not be your patient. You may be seeing the patient whose mother has hypertrophic cardiomyopathy, and then mom needs to have the genetic testing. So that's the type of kind of detective work that we do in our program. We take a detailed 3-generation pedigree for each individual, and then we work very closely with our genetic counselors for pre- and post-test counseling, choosing the right test, and recommending family screening. So these are our genetic counselors in our cardiovascular genetics program. Veronica Fettig is our senior genetic counselor, and Isabel Kornblau is a relatively new addition to our team, and they're really critical to the comprehensive evaluation that we offer. What about the family? So family testing can be really impactful. Just coming back to LMNA, we talked about high penetrance with LMNA. This is a study that looked at the impact of family screening in dilated cardiomyopathies, and 36% of those who were screened developed cardiac dysfunction within 5 years. So there's a real opportunity to capture disease early and implement established therapies in people at the very first sign of disease, as well as to recognize specific risk factors that may put them at a heightened likelihood of developing cardiomyopathy. I want to talk a moment about postmortem genetic testing, not just because Dr. Sampson is in the room, but this is really an important topic that I don't think gets enough screen time. So this is a study from Chris Samsarian that was published 2 years ago. They looked at autopsy indeterminate cases of sudden cardiac death in the young. They defined young as people less than 35. I don't think that's young enough, but less than 35. And they found no cause of death in 40% of those individuals. So they broke down the cohort into people who had some suspicious features of a subclinical disease, so subdiagnostic finding, that's here, versus a normal autopsy is split about 50-50. And when they did a molecular autopsy, so performing targeted genetic sequencing for a set of genes that are associated with either an arrhythmia, which wouldn't really show up with a gross abnormality on postmortem, or a concealed cardiomyopathy, which maybe could explain some of these subdiagnostic findings, they found an actionable result about a quarter of the time. And then they were able to take that information to the families. So these people had lost a loved one. Otherwise, the autopsy wouldn't have really explained what the cause of death was. And if they had, seen a cardiologist, the recommendation would be, well, everyone needs clinical screening indefinitely. But when you now have a genetic molecular diagnosis to explain the cause of death, and you can test the family members, it's a binary result. They either carry the variant and they're at heightened risk and they need that clinical surveillance, or they're negative and they don't need any further management and they can be dismissed and released from care, which can be obviously a big relief. So patients who have a sudden cardiac death should have a comprehensive postmortem evaluation. That's an autopsy, right? And if you can identify a hereditary cause, you can then pursue a genetic workup so that you can more definitively screen family members, especially considering that variable expressivity and reduced penetrance. Not every relative may show features of that phenotype, but they may be at increased risk moving forward. And same is true if there's no heritable cause identified on the postmortem. So I'm going to come back to this in just a second. I know we're running low on time, so I'll speed through this real quick. The pitfalls of interpreting genetic testing results in a bubble. I highlighted a few of these. You want to keep these in mind and just make sure you always consider the genetic context, the clinical context for genetic testing. Okay. How are we doing? Should I wrap up and give time for questions? Okay, that's a shame because this is a good topic, but I was going to talk about genomic screening. And Bayesian analysis. Let me go past these. All right. So let me wrap up with just a few slides here. So 1 in 22 patients with have high-risk genotypes predictive of monogenic cardiovascular diseases. These are individuals who are just sitting in your clinics. They're not being tested specifically because they have symptoms or because they have any particular manifestations or features that brought them to cardiovascular attention. This is just in a clinic population, an unspecified clinic population. So we should be screening for these things even if they're not, even if each one individually is not common. As a whole, these represent relatively common risks for
busy today?
patients. And genetic results are appearing more often as incidental findings through secondary reporting from clinical exome sequencing or direct-to-consumer testing, genomic medicine programs or research studies like biobanks like we have here.
No, I have a lot of paperwork.
And there
also.
are 81 genes now
Just
included
that I'm
on the
going to
American
PT
College of Medical
I have to
Genetics
be there
secondary
2:20.
finding gene list. And half of these are
That's all.
cardiovascular genes, some of which we've talked about today. So more and more patients are going to be encountering results that are not related
Probably
to
a
the
little
particular
earlier.
symptoms that they have, but may raise consideration for future risks or
I may
at
pay a
least
shiver
screening
call
for
on the way home.
cardiovascular disease. And I really like this quote from
I'm
Mike
assuming
Murray
you don't
from
want to pay
an
that shiver
article he
call.
wrote a few years back. The promise of DNA-based screening
Somebody
is
in
that
the
rather
shul,
than waiting
Andrew
for a disease such as
Bordash,
cancer or
you
heart
know, the little
disease,
short
disease
guy.
risk can be identified in a person through
His brother.
screening so that preventive interventions can be offered prior to testing. And
Suddenly.
that's really the basis for Mount Sinai's new Center for
Right on
Inherited
86th Street,
Cardiovascular
across the street from
Diseases.
No,
We're
between Columbus and
addressing
Amsterdam.
genomic and genetic risks and
I can go
facilitating
anytime
genetic
if you want to come.
evaluations for a range of monogenic
Yeah,
disorders,
it's
helping
all
to
day
develop new
today,
models of
tomorrow.
genomic screening and translate genomic research findings into clinical
It's a
care
short
for
little
diverse
guy.
populations.
It's all
These
day
are our
today, all
teammates.
day
We're still
tomorrow
waiting
till
for
9
one
p.m.
big group picture. It's
All
actually
right,
really
glad
hard
I
to
asked.
get everyone in one shot.
So I won't go on my way home.
I just want to also put up this screenshot for how you can order a referral for ambulatory consult for cardiovascular genetics. This is really for the adult-only side of our program. I showed you the picture that includes Bruce Gelb and Mafalda Barbosa. They see predominantly the pediatric cases in cardiovascular genetics. And the last thing I just want to pop up is something new. So because of the need for more postmortem genetic evaluations, we work closely with Mahima, who you may know is a clinical informaticist. She was amazingly helpful in helping us modify the deceased patient order set in Epic. So for the residents in the room, when you are entering the deceased patient order, you might have seen this already. Sorry. But there's this extra step after the notation about autopsy and getting consent. There's another notation here about postmortem genetic testing. And the recommendations are to consider postmortem genetic testing for either a confirmed aortic dissection, a fatal MI in a male less than 45 or a female less than 50, cardiomyopathy without known prior genetic evaluation, sudden cardiac arrest or death, and you suspect an arrhythmia, or out of hospital arrest and no clear etiology. If
You
you
say it's
have a
bad, then I don't
deceased patient who
wanna,
meets one of these characteristics, you can put in the order set the inpatient consult to postmortem genetic testing.
Huh?
And basically what that does is triggers our team to
Yeah.
communicate with the lab wherever they are in the Mount Sinai system and hold on to a blood sample that's been collected for clinical purposes. And then we're able to have that
No.
sent over to pathology
Like-
for a DNA extraction, and then our team will reach out to the next of kin and offer a genetic evaluation where they can consider whether they want to have genetic testing performed. But at least we have the opportunity to collect the DNA. The in-house lab samples are discarded after about a week, so the time here is fairly sensitive. When you place the order, this is what you'll see. And again, if you do decide to place this order, please let us know. In addition to placing the order in Epic, let us know either by email or phone. The instructions here say to use Amion, but we actually don't have a listing for cardiovascular genetics in Amion. So the best thing would be to just call or email us. And this is the summary. Let me just leave time for questions here. Thank you.
I just want to add that you should, if you're ordering postmortem genetics, you should also be requesting an autopsy because the two will go.
Yes. Thank you, Dr. Simpson.
Any other questions from the audience? Oh, Dr. Kraft?
Very nice talk. Just any comment that in a general clinic population, 1 in 22 patients will have some type of genetic risk factors for heart disease. So many of the patients we see, whether we're talking about general medicine clinic or specialty clinic, have cardiac disease of various severities. So I guess I want to get a better sense of a threshold doing genetic testing, because we all see a lot of patients. I'm thinking about for the residents having a general medicine population that they see. Are there some key pros you can provide that would help us pull the trigger on that?
Yeah, I would say there's two key considerations. One is when there's an obvious characteristic, like if they have an LDL level greater than 190. So that would be a threshold to consider familial hypercholesterolemia testing. Another example is, if you're performing an echo on someone for palpitations, let's say, and they happen to have a dilated aorta, it's an incidental finding, but it's worth pursuing the genetic workup. If you're taking the family history and there are characteristics that are suspicious, like a first-degree relative who died in a single-driver motor vehicle accident or accidental drowning, or where they tell you, oh, my mom had heart failure when she was 40, or even later, family history of heart failure, and especially if they didn't have a known ischemic basis. It's not that all of these patients necessarily need the genetic test itself, but at least the workup from the specialty team to decide on whether it can be helpful. Did that answer the question?
Sure. Thanks, Amy, for the terrific talk. So this information, a lot of it's new, a lot of it's very complex, and I guess how is it communicated best electronically to patients in our system? For example, we have someone who shows up in the ER, 33-year-old with syncope, and maybe they don't remember to tell us they had genetic testing, which shows an increased risk for sudden cardiac death or ventricular arrhythmia. Is there a way that's sort of documented clearly for us in the problem list or elsewhere in the EHR?
God, I wish Dr. Darrow was here. Maybe he's. I would say there are efforts
How you
underway
doing?
to try to.
I'm upright. How are you?
Address that. At the moment, I
Good
think
morning.
you're right, it's not so obvious. Part of the problem is that we do genetic testing through outside laboratories. So Mount Sinai doesn't have in-house testing for the cardiovascular genetic conditions that we are interested in. And so the results are scanned into the media as a PDF, right? And actually, ever since the Epic upgrade last week, I can't even figure out how to search for terms anymore. Maybe someone here can show me. But I used to be able to search the word genetic, and then you could, it would flag it if they had seen us, right? Or if they'd seen the genetic counselor, if they had mentioned this in a previous encounter. But yeah, it's a problem. I'm sorry. Wish I had a better answer.
Okay, I think we're at time, so thank you so much, Dr.
Thanks.
Kontorovich.
Thank you.
Great talk.
Sorry.